Dr. Hema Sundaram discussed how to choose appropriate candidates for sclerotherapy and how a foaming technique can make the procedure more effective.
Good candidates for sclerotherapy are patients who have visible spider veins, as we commonly call them. These are the fine diameter red and blue veins on the legs, and medically speaking we call those telangiectatic or reticular veins. The patient needs to understand that there is going to be most likely some recurrence of the veins in years to come, so that ongoing maintenance treatments will be needed. And the patient needs to understand that the primary reason for performing the sclerotherapy procedure is for cosmetic purposes, to improve the aesthetic appearance of the legs. The usual contraindications apply, such as the fact that patients who are pregnant or lactating, have systemic disease or local infection at the site of injection. They should not be injected. There are some specific contraindications that apply to sclerotherapy. For instance, certain patients who have, for instance, a patent foramen ovale, which means that there would be backflow of the blood into the arterial circulation, they may not be good candidates for sclerotherapy because they may not get good results, and there may be a high risk of recurrence of the varicosities after treatment. Similarly, patients who've had an allergy to a sclerosant or an adverse event after sclerotherapy previously would not be good candidates. Patients who have acute deep venous thrombosis.
What are some of the latest techniques in sclerotherapy?
The field of sclerotherapy has really advanced over the past several years. I think it's a very exciting field to be involved with. One of the big advances just came last year, which was the FDA approval of polidocanol under the brand name of Sclera. Polidocanol has been available for sclerotherapy in most of the rest of the world for many, many years. I think it's the gold standard of treatment for sclerotherapy. And prior to its approval in this country, we did not have a sclerosant with that good a safety and efficacy profile. So I think that one really big advance has been the recent FDA approval of a Sclera, and I would highly recommend that to all practitioners who are performing the procedure. A second innovation, which has been around for a number of years, but we have now studied in more detail and determined to be really a gold standard of care for patients who have veins which are beyond a certain diameter, probably between 1 and 5 millimeters in diameter. This is foam sclerotherapy, where we are mixing a relatively small amount of the sclerosant with a larger amount of air, creating a foam by passage of the air into the sclerosant, which has a consistency kind of like shaving foam. The advantages for the patient are firstly that we get much better displacement of blood from the vessels after injection, and therefore a much better contact of the foam sclerosant with the vessel walls. This translates into greater efficacy of the sclerotherapy procedure. Another advantage is that because we are mixing and effectively diluting the sclerosant 3 or 4 times with air, we are reducing the dose of sclerosant that is being administered to the patient, and that can translate into a lower risk of adverse effects. My tips for the dermatologist looking to add sclerotherapy to the practice are, first of all, to make sure that you have a good working familiarity with the vascular anatomy of the legs in order to fully understand how to effectively assess patients. I do recommend performing an ultrasound examination, either duplex or Doppler ultrasound, as part of the patient assessment as an adjunct to the clinical history and examination. It enables us to effectively assess which patients are good candidates for the procedures and to map out a strategy for sclerotherapy for each individual patient that is going to give the best results. Finally, I recommend close follow-up of patients after the procedure. I would recommend a follow-up 3 weeks after each sclerotherapy session. Patients may not necessarily need retreatment at that time, but one can be proactive if there are small clots or thrombi in removing those, extruding them, making sure that the treatment has gone as envisaged both by practitioner and patient, reassuring the patient, and determining that there are no adverse effects.